people are told that you have big breasts because when you are young, there are some, I think there are bags that people used to put on their breasts to grow, to bite. Like yesterday, I just reduced 10 kg, 5 from a 13-year-old girl. You can imagine how she was feeling. And at some point, we actually just removed 300, 350 grams, but it makes a lot of difference. You have active milk production. So if you do any surgery, you're going to have leakages, what you call sinuses. So you don't want to really cut a breast that is actively producing milk. Thank you for having me today. I'm Dr. Martin Ajujo, a consultant plastic, reconstructive and aesthetic surgeon based in Nairobi, NMS, workstation Mama Lucy Kibaki Hospital. I do both public and private practice in Nairobi County. It's not a disease that you can say these are symptoms, these are the causes. It is a normal physiological process that goes wrong. So when now you have a young girl who is having a breast that it goes beyond the normal growth, it becomes big, the breast tissue enlarges, and that comes with weight because it's mass. Mass comes with weight, and the weight is what causes all the problem. So that age of pubertal growth, once you're through that phase, then there's another growth that happens during pregnancy and lactation. And I'm sure for ladies, you notice that when they are pregnant, the breasts become fuller, sometimes tender, and then bigger. And this growth that happens during pregnancy is supposed to involute after breastfeeding, meaning it's supposed to go back. So there's that growth that's supposed to go back. So that is the second phase. So if there are people who have had normal breast growth during puberty, but have another abnormal growth during pregnancy or breastfeeding. And when the breast enlarges during breastfeeding, it doesn't go back. So you have, with subsequent pregnancy, you have bigger breast. Then the symptoms kick in. Weight, then with the weight, you have both physical and psychological torture. So from that description of normal growth of a breast, you can see you can have two types. Yes. You can have the pubertal, or sometimes called primary, or the one that comes during pregnancy and lactation. And in all this, the cause is usually unknown because you cannot predict. You don't say this lady will have this or that, okay? And there's an interaction between the own person genetics and the hormonal, how they react to surge of the estrogen of the female hormones. Sometimes you can find members of the same family. You can find even twins, but you'll have one twin with excessive large breast, the other one will not. So you cannot really say it's a matter of familial, is inherited, or is because of maybe any underlying genetic code that has been found. So in medicine, if you can't find a cause, you just say it's a non-cause or idiopathic. Because if you're able to know the cause and predict, then that means you'll be able to give treatment and cure it. There's that, it's a coincidence, but there's that, let me say, there's that predisposition. So you'd find if your mother had, or your auntie, or in that family, you are at risk of having, but it's not a familial, it's not inherited per se. I'm sure we know this also in our African setting is a new disease because people have been having large breasts, but we didn't know it's a problem. And when you have large breasts that do not cause symptoms, we actually do not treat. We intervene when we have symptoms. Yeah, we don't just say you have large breasts, you have to reduce. Now that becomes cosmetic. But when you have large breasts that are causing you either physical or psychological trauma, then you have to reduce them to be functional and to improve the overall quality of life. Okay, and then there's another category that is caused by whatever you are taking, either some drugs for treatment, cancer drugs, sometimes HIV drugs, sometimes some steroid. So those are definite cause. And for such kind of breast enlargement or macromastia, actually when you withdraw that offending organism or chemical, you actually get treatment. And even if you do surgery and continue having the same kind of medication, then there's a risk of recurrence, as opposed to the other one, which is physiological. Gynecomastia is a very unique thing, because normally for men they're not supposed to have any growth spurt. Okay, for during sex differentiation, the breaking of voice, pubic hair around the axilla, the armpit, but you don't expect, there's no change in the really breast per se. Now in men, you find that if there's excess estrogen for whatever reason, we find they develop what you call, that's why it's gynecological means it's female. So it's a female breast in a man, gynecomastia. And most of the time is because of that growth spurt or excess exposure to estrogen. Either can be during breastfeeding or later in life, especially during when someone is either overweight or obesity. Because some estrogen is formed from fat. To be very simplistic, if you have excessive fat, some fat can convert testosterone into estrogen. Then you have excessive estrogen, then you have excess, what we call man boobs. Yeah. So it's a combination of two things: fat from the weight gain and excess estrogen exposure due to excess fat in your body. Yeah. Now symptoms. The first symptom is excessively enlarged breast. And then that breast, because of weight, it gives you physical symptoms of pain. Most of the time, usually shoulder pain, neck pain, back pain, which can be upper back or lower back. Then you have difficulty in sometimes movement, running, doing physical activities. Then you have difficulty in finding fitting bras or fitting dress. Or if you have a dress that you must do touch up or for you to get relief, because the upper part is bigger than the lower part of your body. Then there's psychological trauma, that is stigma, depression at some point, and insecurity, low self-esteem. In male, there's no weight, so it's just mostly usually physical appearance of breast. So you find men who have gynecomastia, they cannot be shirtless. They must have a jacket even if it's hot, like today. They try to hide. They cannot do swimming. They are withdrawn, and it has immense psychological trauma because of that stigma, low self-esteem and self-doubt, especially in male patients. And when you do that, when you do whatever treatment you do, which I think we'll go into it, there's almost instant relief, and that we can actually see people changing their outlook, their self-confidence, self-awareness. Normally, in medical practice, there's what we call clinical evaluation. So you get the history from a patient. They'll tell you what are they presenting with, what is the major issue, the complaint. Then you interrogate that, and then you find, have they had any intervention? Is there any underlying issue? Is there any medication? So you combine that, and then you do what we call physical examination, because now you have to confirm is what you're being told from history telling you what you see as a trained clinician. So when you combine those two, you'll have what is called your impression or your diagnosis. So you say this is symptomatic gigantomastia or macromastia. If you want to evaluate further, you'll do an ultrasound just to confirm. Sometimes you do a biopsy, and you go further. For you to do those investigations is actually to rule out any other issue, or if it does not present typically, because it's a typical presentation of gigantomastia. If you see there's something deviated, maybe you feel a lump, because normally these breasts are just diffuse enlargement, meaning you cannot feel a lump. Is global. The entire breast is just enlarged. Now, and sometimes you find a point where there's that diffuse enlargement, but there's also a breast lump. Now, in that case, you have to investigate that breast lump, because you can have breast cancer in a setting of gygantomastia. Yeah, so that's when now you'll be forced to go an extra mile and do an investigation. However, even despite having that diagnosis, when you do our breast reduction, whatever tissue you get from reduction, you have to take it to the lab for histology, just to confirm that it was an innocent breast enlargement and not malignant or not cancerous. Okay. Yes. In most cases, when you have enlargement of a single breast, you have become very suspicious. Even in men, when you have gynecomastia but affecting one breast, you have to have very high index of suspicion, because most of the time is malignant, it's cancerous as opposed to diffuse. Because from where I've tried to explain the cause, it is diffuse, it's hormonal. So it's a growth thing, it's physiological. So there's no way your body can decide just to enlarge one breast and not the other, unless it's a cancerous or it's a growth that is isolated to that area. Cancerous or a tumor. You can have a tumor that is not cancerous, it's just a growth.
Yes.
So in most of the cases, you can have a tumor like, let's say, fibroadenoma, or which is not cancerous but is a growth, or other what we call benign tumors. But it's unlikely to be macromastia or gigantomastia. Now, this is what we usually say. There's no single breast that is the same. It's like your fingerprints. Let's start from there. So you cannot say this is an ideal breast. Even the measurements that we use to measure are not ideal. They are like a map, a guidelines. As we do the reduction, there are measurements that we do. Those are just guidelines. And even so, there are many studies that have been published locally and even abroad, that the volume of breasts that you reduce does not determine the symptoms. You understand? So you can have somebody, like yesterday I just reduced 10 kg, 5 from a 13-year-old girl. You can imagine how she was feeling. And at some point we actually just removed 300, 350 grams, but it makes a lot of difference. So you look at your body frame, your BMI, your height, and your symptoms. Yeah. So we can't tell you that every other person should have, let's say, Cap C, or let's say 34B. Yeah. It is individualized. Is what symptoms are you having? What is your size? Because in fact, sometimes you move from extended double D to a C. And there's someone who comes with a C that has symptoms. So you have to move to maybe a B. Yes. And in some instances, people come with C and they want augmentation. What you're asking? They want implants, or they want to have bigger breast to move from a C to a D.
Okay.
So really, it's individualized, if I may answer that question. Okay. But the symptoms guide your choice of treatment. It's the symptoms, the body frame, and then how it will look. Because you cannot do an excessive reduction, then I give somebody a flat chest. Because you must also have maintained the feminine look. So it's all individualized in terms of your symptoms, the size, your body frame, and are you small, are you big, so that it's more of an art plus the science behind it. Now for men, we can say it's standard, because men do not need breast. Okay? So for men, you remove as much as possible. You just you retain very small tissue to just hold the nipple not to sink, what we call buttonhole deformity. But you remove entire. If you don't remove, for men, that's what we found out. If you don't remove the tissue, the breast tissue, as much as possible, you get recurrence. Okay. For men. So for men, you can say it's standard. If you come, we don't have a size. Okay. We remove the entire breast tissue with fat and just leave a cuff to support the nipple or the nipple areolar complex. Most of the patients, some of them, I may say about 40%, usually come after their first pregnancy. And what they'll tell you is that during that pregnancy, they were unable to breastfeed because you have an enlarged breast. The ducts are compressed by the enlarged breast tissue, so there's no milk let down. And they'll have persistent pain, poor breastfeeding. After I do reduction, there's improved in milk letdown, and because the ducts have opened up, the breast is smaller, so the baby is able to breastfeed. However, we are not able to do breast reduction surgery during pregnancy, of course, because we are taking care of the baby, and during breastfeeding, because you have active milk production. So if you do any surgery, you're going to have leakages, what you call sinuses. So you don't want to really cut a breast that is actively producing milk. Otherwise you'll have issue with healing. So usually tell them you have to finish breastfeeding and then come for a reduction down the line. Symptomatic gigantomastia. Treatment is surgical. Surgical, meaning you have to reduce the breast because it's mechanical. You already have an enlarged breast. Weight, mass causing symptoms. So the only way you can deal with that mass is reduce that mass. Weight loss has not been shown to work because people thought that is because of weight is fat, it can reduce, but it doesn't. It's not just fat, but the gland itself has enlarged. There is no tablet or any medication that you can be given to reduce your breast. So the only treatment option is surgical. Now when you go to surgical, now that's when you start discussing what are the surgical option approaches, and those are now technical terms. Okay, but basically you reduce the breast, you relocate the nipple to its rightful position, because when you have enlarged breast, the nipple is usually pushed down. And the tissues are stretched. The nipple stretches, become bigger and lower. So you resize it, push it back into position, and then lift your breast. You mold it as you do your reduction. The common question that people ask is, can I breastfeed? And my answer is usually, yes, you will breastfeed, but the amount of milk let down is what is variable. Okay, the volume of milk is variable. So it can either be reduced, it can remain the same, or it can even be increased, because what I said, the ducts are now more open. Okay, so a lady will be able to breastfeed after breast reduction, but the amount of milk let down is what is variable. The other thing is sensation, because it's very important, nipple sensation. So the technique we use is we preserve the nerves. But because you've done surgery, you've reduced mass, you press sometimes nerves, the sensation is also variable. Remain the same, reduced, or can be slightly go high as the nerves regenerate. The other important question is about scarring. Because you're doing surgery, anytime you do surgery on any part of your body, you've cut. So it depends with your body. There are people who develop excessive scars. So we have to, as we are screening them for surgery, we have to be aware of that and institute appropriate care. Some of the common complications, they are infections. Like any other surgery, you can have surgical site infection where you cut, you get local infection, which can be either superficial or deep, and the other anesthetic complication, because you're doing under general anesthesia. Okay, which you have to be fit for surgery, because sometimes you find somebody who has excessive large breast or gigantomastia with other underlying medical condition. Either you're diabetic, hypertensive, you're on medication, or not. So it's a wholesome. So you don't just treat the breast, but you treat you wholesome as a human being, so that you try to mitigate complications. The latching. Because what you do, you just relocate the nipple, you maintain the gland. So depending on the size of breast that you've removed, that will affect the degree of breastfeeding. If, let's say, you've removed almost the entire breast, that means there's reduced gland tissue, so there'll be no milk let down. But if you just do sizable reduction, they'll be able to breastfeed. But in some instances, then they'd have to supplement with supplementary feeds, because of the amount of milk let down that is determined by the amount of tissue that you have removed. One time we were in Meru, that was a very sad case. It was a young girl, I think 22-year-old, that actually had the spine had actually broke because of huge breasts. Because I told you the issue is weight.
Yes.
And in some country and some jurisdiction, actually, women have sued insurance for negligence, for not approving these surgeries, because it's a progressive disease. So if you don't reduce on time, the breast will keep enlarging. And with the weight comes more severe and severe.
Yes.
So you will have ulcers sometimes as the nipple is being pulled apart. So you have ulcers around the nipple, which can even in the long term convert to become cancerous, what you call Majoline ulcers. Then you have the grooving, which also cause some ulceration. So you'll have wound on the nipple, and you've seen that, and wound around the shoulders. Then below the underneath, you not only have wound, but sometimes thickening and skin changes. Okay, and you, in some instance, you find that some patients that are really they're like disabled, they are unable to function, do the activities of daily living. They can't take simple bath, they can't feed because they have excessively enlarged breast. So that it's a progressive disease. You have to intervene to avoid getting there. Now, it's a costly procedure because of one, the surgical time. If you're doing as a team, you do about 3 hours to 4 hours. If you have to do alone, you can even go up to 6 hours. Because remember, you're carefully releasing a breast tissue as you're maintaining blood supply to the nipple, and then you're contouring that breast so that it maintains form. So it's not a matter of just chopping and throwing. Yeah, so it's a meticulous surgery from planning. It takes you about 30 minutes to mark and map out around yourself. The surgery takes 3 to 4 hours, sometimes 6 hours. So there's an aesthetic time, the team, the consumables that you use a lot of sutures to put it together and all that. So it costs between 5 to 800,000 depending on the hospital, whether private, public. I can say the more we've talked about it, we have received very positive response from insurance companies, and especially if they have symptoms that are justifiable, our patients will be able to get covered, both from NHIF and also the private insurers. Because I think it's about advocacy and it's about if you have a case to prove. Because I know there's that risk of people taking advantage of reduction and do cosmetics
surgery
and do a lift over that. But if you just be able to develop a tool, a screen that is agreeable across all stakeholders, I think we're able to help more people to live normal life. What I can tell you is that is the most breast reduction for plastic surgeons, which I'll tell you all the procedures we do, is the #1 procedure. And I can tell you, even in this town, every single day, there's a woman whose breast is being reduced. Yeah. That is how prevalent it is. Is the top. The other one come second or third, but breast reduction is common. And that is inverse to, let's say, the Western world. For them, they do more augmentation, implants and fat, they add. And because of but us, as our body as Africans, we have more enlarged and excessive breast as opposed to the other side. So it's very common. The issue is we cannot get the true prevalence because it's not understood and appreciated. Because I'm sure if you go to the village, there's a woman who has huge breast that is causing her problems, but they don't know this is an issue. In fact, in some cultures, the bigger the better.
The better.
Yeah. But if you are to interview those individual women and ask them if the large breast is a bother to them, they'll tell you it's a bother. One of the most common is that if someone has a big breast or a sagging breast, they're immoral. That's a very common myth and misconception. It's very wrong, and I think it really affects especially our young girls. They feel that if they have excessively enlarged breast, someone thinks that they are either active sexually or something like that. So that is wrong. It's not related to morality or anything. The other thing, it's believed that is a curse. People say that if you have big breasts, it's because either your ancestors are not happy, or your mother or your father has done 1, 2 or 3 things, or your clan is cursed. So that is wrong. It's a normal disease that has nothing to do with the victim. So we should not blame the victim. Other thing that we find is that people are told that you have big breasts because when you are young, there are some, I think there are bugs that people used to put on their breast to grow, to bite. And the other thing is that people assume that any excessive enlarged breast is malignant or is cancerous. So they even fear seeking for help. So that is also a misconception. And some think that even if you do surgery, then it's going to grow. It's going to come back with a vengeance. You say anything that any growth in your body you're not supposed to cut, because if you cut, now you're going to have a bigger growth. That is also a misconception. Yeah. My word on this breast enlargement issue is that it's a real problem affecting different categories of people in our society, both the young, as I can say, people in their puberty, and the middle age, and sometimes even the old age. And when we have excessively enlarged breasts that have pain, and if you know that your breasts are enlarged and they're causing you physical pain or psychological trauma, you need help, and there's help. And there's not something to hide. It's not your fault. It's not something for you to feel bad about it, because it's like any other person who has a growth, that is not their fault. And I think for NHIF and government, I think we are doing a lot of advocacy, because I believe in educating rather than condemning, because maybe sometimes decisions are being made because of lack of information. So the more we talk about, the more people get to understand, and the more people come out and appreciate that this is a thing that needs to be assisted as opposed to be condemned, then our policymakers are going to understand. Because even if you're sitting in an office as a policymaker, with the prevalence of Gigantomastia, I'm sure you have a relative, a friend, or a neighbor who is afflicted by the same. So if we just open our eyes and look around, there's someone we know who has excessively enlarged breasts that are causing pain, and they need our help and understanding. So as a society, I think we have to be more understanding. I think in some cultures it's even a taboo to discuss breast or to even mention the word breast in a dinner table, in a conversation. But in this case, we're not just talking about breast for the sake of talking, but we are talking of breast that is causing physical and psychological pain to our women, the women that we care about. And we must extend that hand of support and help and understanding, and encourage our people who are afflicted with this illness to seek help and to get the proper treatment. Because it's very sad, sometimes you have patients who come to you, they know they have the symptoms, they have the pain, but they're even afraid to mention it to either their parents or their partners, because they don't want to be judged, or they feel they are not going to be understood. But we have to listen more and more to our loved ones who are afflicted, and try to get into their shoes so that we're able to walk the journey together with them. That will be my parting shot.